Hi, I'm Karen Tu, a family physician at Toronto Western Hospital in Toronto, and on behalf of the EMRALD-ISIS team, I'd like to thank you for joining this presentation. I'll be describing the tools our team has built to support your quality improvement efforts, and we'll be focusing on chronic kidney disease as we've received funding from the Ontario Renal Network to conduct this project. The first thing we'll do today is talk a bit about chronic kidney disease, otherwise known as CKD, and show you some of the tools developed to help you manage this chronic condition. Then we'll talk about how you can use the EMRALD-SAFIRE website to get data about the proportion of your patients in your clinic that are achieving best practice quality indicators and to identify patients who may benefit from reassessment. Next, we'll show you some tools we've built for your EMR that make it easier to identify and manage patients who have CKD. Finally, we'll leave plenty of time for questions and discussion. So why CKD? CKD is almost as common as diabetes and confers a similar increase in CVD risk and mortality, yet receives far less quality improvement attention. Studies around the world have found care and knowledge gaps regarding CKD amongst both primary care and specialist physicians. And previous research has found that patients with clearly documented CKD, as recorded in the cumulative patient profile, receive better guideline-based care. Who's at risk? Statistics coming out of the US have found as many as 1 in 3 patients with diabetes and 1 in 5 patients with hypertension have CKD. Other risk factors include increasing age, cardiovascular disease, family history of CKD, and Aboriginal descent. Detection of CKD should be done in the absence of acute intercurrent illness, for example, recent GI illness, excess diuretic use, or recent use of NSAIDs. Testing should be done with both eGFR and urine albumin to creatinine ratio, otherwise known as ACR, which you can get when you tick off microalbumin on the Ontario lab requisition. If you find a test result of an eGFR less than 60, then you should repeat the test in 3 months, as the definition of CKD is a persistently low eGFR, though you could test sooner than 3 months if you have a clinical concern, such as rapid decline from a previous eGFR result or very low eGFR. If the urine ACR is greater than or equal to 3 on initial testing, then you should repeat the test at least 2 out of 3 random urine ACRs must be elevated over at least a 3-month period to meet the definition of CKD. You should always consider reversible causes prior to retesting, for example, NSAID use, recent use of contrast dye, BPH, or urinary retention. There are a few different classification systems for CKD out there, but in general it is accepted that there are 5 stages of CKD based on the level of kidney function. What I'm showing here is KDIGO's classification system. KDIGO stands for Kidney Disease Improving Global Outcomes, and it is an international organization. Stage 3 or higher refers to an eGFR of less than 60, and this is where we focus our attention, because these patients are the patients that we as family physicians play a larger role in preventing further progression. Once patients reach stage 4 or 5, they are usually in the hands of nephrologists. Through working with the Center for Effective Practice, using a modified Delphi panel process that involved representation from family physicians, nephrologists, nursing, and patients, we developed a set of Canadian CKD quality indicators for primary care. We started with over 90 indicators and narrowed them down to 17 indicators that we then applied to the EMRALD data. Next, we removed the indicators where the care gaps were narrow and focused on the indicators that had the largest room for improvement, and have provided feedback to you on these indicators through SAFIRE. This slide shows you how to log into the EMRALD-SAFIRE website. Each physician or their delegate can sign in at any time to access the data. Once you log in, you will see data regarding the proportion of patients in your practice that are meeting best practice quality indicators. In SAFIRE, we have divided the indicators to screening indicators and indicators for patients with stage 3+ CKD. In the SAFIRE analysis, we removed patients with renal transplants and dialysis patients as best we were able to identify through the CPP. Along the top, you will find a frequently asked questions tab. Up here, the FAQ tab, that explains how each of the indicators are calculated, and it also includes brief videos showing you how to use all the functions of the website. In the bottom right-hand corner of the screen, in this area here, is a graph that we call the gap score graph. This depicts the number of patients who have one or more indicators that could be improved. You could use this information to focus on patients who have the highest gap score. Another way to look at the data is to try to use what we call high-risk indicators. This approach shows the proportion of patients in your practice that are above what might be considered a high-risk threshold, such as patients with CKD who should be on a statin and are not, or patients who have CKD by lab criteria but is not documented in the CPP. Again, the gap score can be used in the same way to prioritize patients who may benefit most from reassessment in clinic. To identify individual patients, you simply click on the blue button near the top of the page called the patient list. This is to illustrate what your patient list might look like. If there are some patients on the list that should not be there, you could check the exclude box and we will exclude that patient from future analyses. You could also click download to extract the data into an Excel file, where it is easy to sort by any number of variables. Then you can proactively prioritize follow-up appointments accordingly. We've gotten approval from the College of Family Physicians of Canada to provide you with 2 main Pro C credits for each disease condition you review on the EMRALD-SAFIRE site. To get the credits, you just review and complete the form you see here. It is preferable to review the form with your team to come up with systems and strategies that can benefit all your patients. When you submit the form, it will auto-generate a certificate that looks like this, and then you can submit it to the college to get your main Pro C credits. Now I want to switch gears to look at the tools we have built for use within your EMR. What you are looking at on this slide is a picture of an algorithm that the Ontario Renal Network has developed for the identification, detection, and management of CKD in primary care. We have built a custom form of the algorithm for you to pull into your patient chart once you have identified a patient with CKD. Once you are in the patient chart, you just pull up the custom form labeled EMRALD-ORN-CKD algorithm. Use of this algorithm is appropriate for patients in whom you have already detected CKD. Therefore, this assumes that the patient has had at least 2 abnormal readings over at least a 3-month period. Who you should screen for CKD and diagnostic criteria over here are provided at the top of the form. Your patient's most recent eGFR and ACR will automatically appear here, in this area over here. And depending on the eGFR and ACR value, the appropriate workup and management path will be highlighted to you in blue. This path also gives recommendations on when you should retest your patients. We hope this tool will be helpful to you in the detection and management of CKD. We've also designed a patient handout for chronic kidney disease in the format of a custom form as well. When in the patient chart, simply draw up the custom form EMRALD-CKD patient handout. This handout is intended for use in patients in which you have identified have CKD and is intended to help you with the counseling of your patients. The patient handout provides an explanation of what CKD is at the top and information on how to prevent progression of the disease. It provides a hyperlink to appropriate diet recommendations for CKD, which can be found in Chapter 5 of this manual. It It also provides a hyperlink to advise your patients on appropriate exercise. Here you can type the patient's current exercise duration. Here it auto-populates smoking status. It also provides information on appropriate statin prescribing, blood pressure targets, frequency of monitoring of EGFR and ACR, and whether a flu shot is required. Like all custom forms in PS, this can be printed and handed out to your affected patients. We hope this tool will be helpful to you and save you time in counseling your patients with CKD. We have built a set of reminders based on the quality indicators that were feasible to put into a reminder. Feel free to install any or all of the reminders as you see fit. The reminders utilize the existing reminder functionality in Practice Solutions. However, there are some things to note with these reminders. Since PS reminders cannot be built to detect the two most recent EGFRs or ACRs, these reminders pop up based on the most recent EGFR or ACR. Some may require your modification depending on what nomenclature you use to record the various relevant diseases and how your lab results are labeled in your EMR. For reminders that relate to patients with known CKD, we identify these patients by recording CKD in the problem list of the CPP or the most recent EGFR less than 60. Reminders that use documentation of CKD in the problem list of the CPP may need to be modified to incorporate how CKD is documented in your practice. Thanks so much for joining us. I hope you found this presentation useful. We are pleased to hear feedback from you, so don't hesitate to send comments or questions.